So tonight's lecture, we're going to look at diuretics. This is one of the mainstay in our treatment of heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction as well. But diuretics is one of our main therapy. But as we showed in our Frank-Starling curve, diuretics is mainly for symptom relief, because remember, okay, let's have a look at the that curve again, and we just gonna, so the Frank-Starling curve, where we have the stroke volume on the vertical axis, and on the horizontal axis we have the preload. Okay, and it looks something like this. The normal curve looks something like that, and then the failing curve looks a little bit more dramatic. Okay, and so this would be our normal curve right up here, and this is the heart failure curve, or the failing heart curve. So a lot of time when you get your symptomatic patient with a lot of congestion, they're right here, they're right here, they're right at this point right here. So when you give them diuretics, what you do is to just bring them to a more favorable point in the curve. So you bring them to some place like right here. Okay, so the therapy is going to move them along the failing curve, but to a more favorable position, and you can see that they will have a larger cardiac output, um, because they're moving leftward on the curve. So that's what diuretic does. You don't want to give too much diuretic, then you'll end up someplace down here, and that's going to be less favorable, because you're going to have a reduction in your stroke volume and cardiac output. So the different types of diuretics that we have, of course, they work at different points. They work at different points, and in the tube, the kidney tubules. Okay, and so we have the loop diuretics, and we also have the thiazide diuretics, and we call them the loop diuretics because they pack they inhibit sodium reabsorption at the loop of Henle. Okay, and we will recap what the tubules look like shortly, but the loop diuretics, which is our mainstay in terms of treating acute heart failure. We also use it for chronic heart failure, but you know, they are more potent than the thiazide diuretics. So the loop diuretics includes bumetanide, furosemide, and torsemide. Okay, and then we have the 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 other type of diuretics, which inhibit sodium at the distal portion of the tubule. So the loop diuretics going to inhibit sodium at the loop of Henle, and then these diuretics going to inhibit the sodium reabsorption at the distal portion of the tubule. And we have in this group, you have the thiazides, metolazone, and spironolactone. So as a result of inhibiting the sodium reabsorption, you have increased urinary sodium excretion, yeah, and that give you symptom improvement and increased exercise tolerance. So again, it all it does is just decongest the patient. It remove fluid. If you use a too small a dose, it's not going to result in significant fluid removal, and it will result in fluid retention. And I've seen a lot of patients come to me. They have seen the primary care doctor, and the primary care doctor have done everything, diuretics and stuff, but they just did not put them on enough diuretics. So remember, if the patient is congested, you have to remove the fluid. You have to remove the excess fluid. So inappropriate low doses will result in fluid retention. So use appropriate dose. You have to follow the patient closely to make sure you're removing sufficient fluids. So in the same breath, inappropriately high doses can also lead to volume contraction. And if you remove too much fluid, the patient will become hypotensive and can develop renal insufficiency. So once you have these patients on diuretics, especially the loop diuretics, you should be very aggressive. Daily weights, you have to follow the weights carefully. You also have to get electrolytes, and you have to follow the electrolytes closely. Okay? So you don't want the patient to be volume contracted, develop hypotension, and renal insufficiency. And the diuretic should be combined with your ACE inhibitor, beta blocker, and aldosterone antagonist. Remember, we're talking about stage C heart failure. And just to recap, your stage C heart failure, these are the patients who are symptomatic. Either they were symptomatic sometime before, or they're currently symptomatic. So these are symptomatic patients, unlike your stage A and B, where your stage A patients just have risk factors for heart failure. Your stage B patients, they have structural heart disease, but they're asymptomatic. Your stage C patients are the symptomatic patients, okay? So those patients should be on ACE inhibitor, beta blockers, and aldosterone antagonists. And this is just a recap. You know, when we talk about a class 1 indication, then the benefit far exceed the risk. At class 2A, the benefit outweigh the risk, but you know, not as much as the class 1. And then class 2B, benefit outweigh the risk, and not as much as your class 2A. And then your class 3, there's no benefit or harm. You can do harm to the patient. And you know, so you have a lot of data to support class 1, and you know, class 1 treatment or procedure, you know, is the standard of care. Patients who have some ailment should receive that. If you don't prescribe that therapy, then or that procedure, then that's considered malpractice for class 1. And then with the level of evidence A, B, and C. Okay, so diuretics is a class 1. So you given diuretics is considered class 1, and it is recommended in patients with heart failure with reduced ejection fraction who have evidence of fluid retention. So again, when the patient comes, you're going to take your history, physical examination, and you're going to assess to see if the patient is fluid overloaded. So if there's fluid retention, remember we spoke about some of the signs of fluid retention. You can have peripheral edema, ascites, um, you know, sacral edema if the patient is lying down. But one of the most important feature, sign of fluid retention is your hepatojugular venous distension. Okay, you might have to do your hepatojugular reflux as well. So once the patient have heart failure with reduced ejection fraction and there is evidence of fluid retention, unless it's contraindicated, you should give the patient diuretics to improve symptoms. The patient is going to feel lousy if you don't. Okay, patients are not going to feel, you know, you might give them all the ACE inhibitors, beta blockers, and aldosterone. If you don't remove the excess fluid, they're not going to do well. So when we talk about the different type of diuretics, you have to know a little bit about the tubules. And, you know, this is the glomerulus, of course, and then you have the proximal tubule coming from the Bowman's capsule. This is the Bowman capsule just around the glomerulus. So it's the proximal tubule, and then this is the loop of Henle we're talking about. This is where the loop diuretics work to inhibit the reabsorption of sodium. So this is the descending limb of the loop of Henle, and this is the ascending limb, okay? And then have your distal tubules and the collecting tubules. So the loop diuretics act right here, and then the other diuretics acts in the distal tubule, okay? So one of the most common diuretics, loop diuretics that we use is furosemide. So, you know, furosemide is the go-to medicine, and it's fairly effective. It's relatively cheap, so we use it. But if the gut is congested and you're not getting the desired effects that you used to get, you can switch over to bumetanide and torsemide because these agents have increased bioavailability. You usually start with low doses. So start low and then you increase until the urine output increases or until the weight decreases by about a half to 1 kilogram. So you don't just put them on a fixed dose and leave them and hope that they feel better. No, you have to, you know, what I would do, depending on the amount of congestion, I'll bring the patient back. You know, if it's a patient that you can, you know, they weigh themselves on a daily basis at home, and if you tell them to take two, two tablets twice per day, they can follow the instructions. So patients who have good support follow instructions. You can, you know, manage them at home. If it's not adequate to do that, then you bring them in and you have to get adequate urine output and decrease in weight. And you can also increase the dose of the diuretics or the frequency. You have to remove the fluid though. And you know, I've seen a lot of primary care that do a very good job. They just do, I don't know why they're scared of diuretics. I mean, you have to follow the patient closely. You know, you have to do that. But you remember the symptom relief is important. You have to get the patient free of symptom because that's one of the reasons why they come to you. Okay, so you remember your ultimate goal is to eliminate clinical evidence of fluid retention. You have to remove the fluid as the patient is not going to feel well. And you're going to combine that with modest dietary sodium restriction, reduce the amount of salt. Um, in some patients, you want to continue the dose of the diuretics on a daily basis to prevent the recurrence of fluid overload. However, again, if you have a patient that's engaging, you can stop the diuretics and you can give the diuretics on a PRN basis. That is, you know, patient do daily weights. If they gain more than X amount of weight on a daily basis, and we usually say 3 pounds, then if they gain more than 3 pounds on a basis, then you can, increase the diuretics. Okay. All right. All right. Again, the daily weight is very important. So, um, you know, all your patients with heart failure should have a scale at home so you can effectively manage them. They don't have to run into the office or to the hospital every time. You know, if they gain significant amount of weight, you have documentation of that, and you can tell them what to do. If the patients are unresponsive to large doses of your diuretics, and we have these patients over and over again. So if the patient is unresponsive, you have to, determine why they're not responding to the diuretics. They may be consuming a large amount of sodium. So that's one of the things that will reduce the effectiveness of the diuretics, large amount of sodium. They may be taking NSAID, non-steroidal anti-inflammatory drugs, taking Motrin because they have a toothache or a headache or something like that. So the medicine is no longer effective. Or they may develop renal impairment, impairment of renal function or perfusion, which makes the diuretic less effective. So you have to look for these things. If you want to overcome diuretic resistance, you can do IV dosing. Okay, so a patient accumulating a significant amount of fluid and they're not responding to the PO diuretics, you might put them in the hospital, give them some IV diuretics, or you can combine different diuretic classes, such as a loop diuretic with metolazone, or a loop diuretic with spironolactone or aldactone. So that strategy is very, very effective. So IV dosing or a combination of different diuretic classes. Okay. So these are the diuretics that we use. The bumetanide, known as Bumex, we usually start with a low dose, 0.5 to 1 gram once or twice daily. The maximum dose is 10. The duration of action is about 4 to 6 hours. Furosemide, Lasix, you start with 20 to 40 once or twice per day. You can go up to 600. Usually, when I go up, I get called, the pharmacists go crazy in some places. Okay? I mean, outside of the United States. In the United States, they outside of the United States, the pharmacists go crazy, and I don't think they understand that the maximum dose of furosemide is very high. You have to achieve the desired diuretic effects. Okay, you can go up as high as 600 milligrams. All right, torsemide starting at 10 to 20, and you can go up to 200. And then uretiazide diuretics such as chlorothiazide. The dose is 250 to 500 milligram once or twice, and you can go up to 1,000. Your chlorothalidone, which I tend to use a lot, the starting dose 12.5 to 25 once daily. And this is, this is not a bad diuretic, but it's a very good blood pressure medicine. Okay. And you can go as high as 100 milligram. It lasts a long time, 24 to 72 hours. So this is a very good blood pressure medicine. The hydrochlorothiazide, again, starting dose 25 once or twice per day, up to 200. Duration of action 6 to 12 hours. Okay, and then indapamide, the metolazone. I usually use metolazone to potentiate the loop diuretics. Okay, this is, we call it Xeroxilin. And then you have the potassium sparing diuretics such as amiloride. We use a lot of spironolactone, start at a low dose, 12.5 to 25, and can go as high as 50. So these are the diuretic class. You need to, know one non-loop diuretic very well, and if that's your go-to medicine, you should know everything about it. You need to know one of the loop diuretics very well, and then if that's your go-to medicine, know how to use it very well again. So the combination of these medicines in diuretic resistant patients is a very important one, because from time to time you're going to have patients coming back and say, well, I'm not peeing as much, so you need to understand what's happening. Is the patient eating too much salt? Are they taking NSAIDs? All right. So what are the risks involving using diuretics, the risk of treatment. So electrolyte depletion, remember we said it inhibits sodium reabsorption and you also lose potassium. So electrolyte and fluid depletion, these patients can become dry, volume depleted, and develop renal impairment. So you have to follow the patient closely, so they can develop fluid contraction, hypotension, kidney impairment, potassium and magnesium depletion. And remember, a low potassium and magnesium can give you cardiac arrhythmia, and patients can die if they have very low potassium and magnesium. So if you're going to treat these patients, you have to know the medicine, know the adverse reactions that can occur. So the next medicine that we're going to look at is ACE inhibitors, angiotensin converting enzyme inhibitors, and it's a class 1 indication for patients with heart failure with reduced ejection fraction. And the statement reads that ACE inhibitors are recommended in patients with heart failure with reduced ejection fraction and current or prior symptoms. Unless it is contraindicated, it reduces morbidity and mortality. Okay, so it's your class C patients. So remember, these are patients who have heart failure with reduced ejection fraction with current or prior symptoms. These medicines, if you don't give it to your patient, it's malpractice because it is indicated. It's reduced morbidity and mortality. So you have to know the class 1 indication. So if we look at the renin-angiotensin system, and we're going to quickly review that, then renin, which is produced by the kidneys, okay? So renin produced and released by the kidneys is going to act on angiotensinogen. Angiotensinogen is produced in the liver. So your angiotensinogen is going to be converted to angiotensin 1 by renin, which is released from the kidney. So the renin is going to convert your angiotensinogen to angiotensin 1. Angiotensin 1 is going to be converted to angiotensin 2 by ACE, angiotensin converting enzyme. Okay? And then your angiotensin 2 acts on the blood vessels to cause constriction and can give you hypertension. Your angiotensin 2 also acts on the adrenal gland to cause the release of aldosterone. Okay? So in a nutshell, this is the renin-angiotensin system. When we give an ACE inhibitor, it blocks this step right here. It prevents the conversion of angiotensin 1 to angiotensin 2. So therefore, the vasoconstrictive effects of angiotensin 2 will not be realized because you're going to block the synthesis of angiotensin 2. Okay? So that is what ACE inhibitors does. So studies have shown that ACE inhibitors reduce death and rehospitalization. The benefits are seen in patients with mild, moderate, or severe symptoms. Whether the patient have coronary artery disease, yes or no. So anything that reduces death and rehospitalization is very key. It is a class 1 medicine. If you don't give it, that's malpractice. Okay, so all patients with heart failure with reduced ejection fraction, unless contraindicated, ACE inhibitor together with a beta blocker should be given. Okay, however, so there's a caveat, and then people doing exams need to be aware that you shouldn't give it if the patient experiences a life-threatening adverse reaction such as angioedema. If the patient had a previous reaction, angioedema, that is swelling of the throat because of an allergic reaction, the ACE inhibitor is contraindicated. You should not give it. Okay. Now, again, you should not give it if the patient is pregnant. So you don't give it in pregnancy. And again, you need to know the medicines, the medicine that you don't give in pregnancy. Those going to pop up at all exams. Okay, you don't give ACE inhibitors in pregnancy. You have to be very careful if the patient have a low blood pressure, and we're talking about probably less than 80 millimeters mercury. So your ACE inhibitor for heart failure, ACE inhibitor does a lot of things. It's a vasodilator, and it also have a favorable uh, response to some of the hormones, the compensatory hormones that are released. So if the blood pressure is low, you have to be careful. If the serum creatinine suggesting that there's renal impairment, you should also be very, very careful. And we talk about a creatinine greater than 3 milligram per deciliter. If the patient have bilateral renal artery stenosis, be careful. And then if the potassium is elevated and the number they pick is 5 milliequivalents. So the data suggests that there's no difference among the different class of ACE inhibitors. So you're safe to use whichever ACE inhibitor you're comfortable with, because the data didn't. I mean, there are a little bit of difference here and there, but in terms of survival and symptoms, you can choose any one. Again, start at a low dose and gradually increase. If the patient tolerates the lower dose, you can increase to the higher dose. Be careful, look for impairment in renal function. Make sure you check the potassium. You need to do an assessment about 1 to 2 weeks of starting therapy and then periodically. Okay. Most of the medicine that we use to treat cardiovascular problems, we always try to mimic the studies. So whatever dose was used in the studies to show improvement in survival or morbidity, whatever, you try to see if you can achieve those doses. So don't start at the lower dose and just leave it like that. If the patient tolerates the lower dose, you try to increase the dose to get to the study dose. And try not to do abrupt withdrawal of your diuretic, of ACE inhibitors as well. So these are we have some older ACE inhibitors here. I'm not going to talk about them. Captopril is the older one. Fasinapril. The current ones are enalapril. And we usually start with a lower dose, 0.5 milligram twice daily. Enalapril is a twice daily medication. And you can go up to a maximum of 10 to 20 milligram twice per day. In the study, they used about 16.6 milligrams daily. And then for lisinopril, you start low, 2.5 to 5 milligram once daily. So again, it's a once a day formulation. Maximum dose is 20 to 40. The dose that they studied in the trials were 32.5 to 35 milligrams daily. So we still use ramipril and trandalapril still used. Perindopril is used outside of the United States, but again, low dose and you increase accordingly. Try to get to the dose that was used in the studies, okay? So what are some of the risks involved with the ACE inhibitors? We suppress angiotensin, so angiotensin suppression, and we get kinin potentiation, and this is responsible for the cough that you get with the ACE inhibitors. So ACE inhibitors associated with a troublesome cough, and up to 20% of patients will experience a cough, and that's because of the kinin potentiation. So be aware of that, and if If the patient develops a cough, you might want to switch to something else. They can also get a rash and some taste disturbances. Again, pay attention to the volume status, the renal function, and whatever other medication you're using, because you can get elevation in the potassium level. So if you're using an ACE inhibitor with, say, aldosterone antagonist, you can get elevation in your potassium level. So be careful, watch that. But about 85 to 90% of the patients can tolerate the ACE inhibitor, not a problem. What about HARBs, angiotensin receptor blockers? So these medicines, they get a class 1 indication, and they're recommended in patients with heart failure with reduced ejection fraction, with current or prior symptoms, who are ACE inhibitor intolerant. So if the patient is ACE inhibitor intolerant, HARB is shot up to class 1. Okay? Angiotensin receptor blocker gets a class 1 indication, unless, of course, they're contraindicated to the HARB. And the HARBs reduce morbidity and mortality. Okay, so they reduce both morbidity and mortality as well. They have a class 2 indication, however. So they get a class 2A indication where they reduce morbidity and mortality as well, as an alternative to ACE as a first-line therapy. So you didn't want to use the ACE inhibitor, you just go with the HARBs. It get a class 2 indication in that situation. Okay? And one of the scenarios, if you were treating the patient for hypertension and they were on a HARB for the hypertension, you probably want to leave them on it and then add your beta blocker and stuff like that. But the class 1 indication for HARB is when they're intolerant to the ACE. Okay? They get a class 2B indication. If I wouldn't. You can add the HARB to ACE if the patient is problematic. I would not do that. Okay? Very, 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 very few patients have an ACE and a HARB together. But if you want to do that, you can do it. It's a class 2B indication. The patient have to be very sick though. If the patient is persistently symptomatic, so very sick, you can do it. Not your regular patient. Okay. Class 3 indication. So routine combined use of ACE inhibitor and HARB and aldosterone is potentially harmful. You can get significant hyperkalemia and the patient can run into problems. So you don't want to do that. So the ARBs, angiotensin receptor blockers, they were developed to reduce the adverse effects of the ACE inhibitor. And several placebo-controlled studies have shown that they reduce hospitalization and mortality. ACE inhibitors, however, remain the first choice, the inhibition of the renin-angiotensin system in heart failure patient with reduced ejection fraction. And again, remember, ARBs is just an alternative. It gets a class 1 indication if the patient is intolerant of ACE. So if the patient is intolerant of ACE, then HARB gets a class 1 indication. If they're taking it for hypertension already. So again, people doing exams, ACE inhibitor can cause angioedema. For some reason, it's a little bit more in blacks, but less than 1% of the patients. But it's a lifetime avoidance, because if they had it before, they can get it again, they can have it again, and this can be life-threatening. So you don't want to, that's one of the history you want to find out. If the patient was taking an ACE inhibitor and they say, I'm allergic to it, or you look in the chart and they say, what type of allergy we're talking about? Is it angioedema? If it's angioedema, no more ACE for them. Some patients can develop angioedema with HARB. It's not as common, but some patients can develop the angioedema to HARBs. For HARBs, you have the same concerns: renal impairment, hyperkalemia. Start with low dose, gradually increase, okay? And then the problems associated with HARBs: hypotension, renal dysfunction, and hyperkalemia, same things. So these are the HARBs that we have in use. Candesartan, start 48 milligram once daily, max out at 32 milligrams. This is the dose that was used in the studies, 24 milligram. Losartan, we use a lot of losartan. Start at 25 to 50 once daily. They can max out at 50 to 150. I had prescribed 150 for a patient, and the pharmacist tell the patient that that's exceeding. So, it's difficult to, but anyway, you should know the maximum dose of whatever you're going to use. And, so this is the dose that was used in the study. Valsartan, start with 20 to 40 twice daily, and you can go as high as 160 twice per day. This is the dose that was used in the medicine in this trial. Beta blockers. So, the thing about it, these medicines are very boring because, you're just learning the medicine and stuff like that. And but they're extremely important, and you have to know how to use them. So beta blockers is not one of the mechanism that we looked at before. So remember the mechanism we talk about preload reduction, afterload reduction, increased contractility, medicines to modify the compensator mechanism. Well, what beta blockers does, and beta blockers sort of they upregulate the beta receptors. In addition to decreasing the heart rate, they upregulate the beta receptors, and over time, you get increasing contractility of the heart. For heart failure with reduced ejection fraction, it's only 3 beta blockers that were found to be effective in terms of reducing morbidity and mortality. People doing exams, people treating heart failure should know this. All beta blockers are not equal in this regard. So the use of one of the 3 beta blockers proven to reduce mortality, and those medicines are bisoprolol, carvedilol, and sustained release metoprolol succinate. It is recommended for all patients with current or prior symptoms of heart failure with reduced ejection fraction unless contraindicated. These medicines reduce morbidity and mortality. It's a class 1 indication. So if you have a patient with heart failure with reduced ejection fraction and they're not in one of these 3 beta blockers, then that's malpractice again. Okay? So what the beta blockers does, they lessen symptoms, they improve the clinical status of the patient, and they enhance the patient's sense of well-being, and they reduce the risk of death and combine death or hospitalization. Again, these are the only 3 beta blockers. You have atenolol. Atenolol did not do it. You have metoprolol tartrate. Metoprolol tartrate did not do it. So the other beta blockers did not produce the desired effects of reduction in morbidity and mortality. It's bisoprolol in the Caribbean. I think that's Concor. And we have sustained release metoprolol succinate, that's Toprol XL in the United States. And then we have carvedilol. So these are the medicines that have been shown to reduce morbidity and mortality. They also reduce the risk of disease progression, reduce clinical deterioration, and reduce sudden cardiac death. Again, just like any other medicine, you're going to start at very low doses. gradual increment. If the lower dose is tolerated, you're going to gradually increase. What are some of the adverse effects, problem related to the beta blockers? You can get fluid retention, worsening of heart failure. So you want to wait until the patient is compensated a little bit. The patient comes into the hospital, is in heart failure decompensated. You want to compensate them a little bit before you start your beta blockers, okay? One of the main problems with beta blockers is fatigue. Very good medicine, but they can cause fatigue. So you have to pay attention to that. You can get bradycardia and heart block, hypotension. Okay, since these are the guideline directed beta blockers. The bisoprolol start at 1.25 milligram once daily. The maximum dose is 10 milligrams once daily. And the dose in the study was 8.6 milligram per day. Carvedilol start at 3.125 milligram twice daily. It can go as high as 50 milligrams twice daily. The study dose was 37.5 milligrams per day. And then carvedilol CR start at 10 milligram once daily. You can go as high as 80. Okay. Metoprolol succinate start 12.5 to 25 once. So it's a once a day medication. You can go as high as 200 milligram once daily. In the study, they use 159 milligrams. Okay, so we'll just wrap up with aldosterone antagonists. Now, aldosterone antagonists is very effective, and this medicine it reduces the compensatory mechanism that occurs in patients with heart failure. We showed you the renin-angiotensin system before, and you know, it can be used as a diuretic, but in heart failure, we're not using it as a diuretic. So it gets a class 1 indication. So people doing exams, class 1 indication, aldosterone receptor antagonists or mineralocorticoid receptor antagonists are recommended in patients with New York Heart Association class 2 to 4 heart failure who have an ejection fraction of 35% or less, unless it's contraindicated. It reduces morbidity and mortality. Okay, class 1 indication. EF 35 or less, they should be on aldosterone receptor antagonists. Patients with New York Heart Association class 2 should have a history of prior cardiovascular hospitalization or elevated plasma natriuretic peptide levels to be considered for aldosterone receptor antagonists. The important thing about aldosterone antagonists, spironolactone, aldactone, you have to be careful when you're using it. You don't want to use it if the creatinine is more than 2.5 milligrams in male or 2 milligrams or less in females. Okay, so if there's any type of renal compromise, you're going to be very, very careful, and that, you know, so you want to make sure the creatinine, the glomerular filtration rate is greater than 30. And you have to be very careful if the potassium is higher than 5. You want to make sure the potassium is less than 5. So to start the aldosterone antagonists, you want to make sure your creatinine in males less than 2.5, in females less than 2, and your potassium is less than 5. You have to monitor these patients. Once you put them on the aldosterone antagonists, you have to monitor them. So after you put them in it, within 3 days, you have to get an electrolyte. Okay, you have to get an electrolyte level, and then in another couple of weeks, and then monthly. Okay, so you have to know how to manage these patients. You don't just leave them in the aldosterone antagonists and think everything is going to be okay. So aldosterone receptor antagonists are recommended to reduce morbidity and mortality following acute MI. So in addition to your regular heart failure patients, if the patient had a prior heart attack, okay, it can reduce morbidity and mortality if their ejection fraction is 40% or less. With your regular heart failure, 35% or less. But if they had a heart attack now, if the ejection fraction is 40% or less, or if they develop heart failure symptoms, or if they have a history of diabetes mellitus, they should be on the aldosterone antagonist. And then class 3, you don't give it if, as we mentioned before, if they have high potassium greater than 5, if the creatinine in a male is 2.5 or greater, or 2 in a female, if they have significant renal compromise, you don't want to give it. Okay. In the RALS trial, and the acronym stands for Randomized Aldosterone Evaluation Study, aldosterone receptor antagonists had a 30% reduction in all-cause mortality. It reduced death in 30% of these patients. And patients had chronic heart failure, which reduced ejection fraction. EF was less than 35%. So 30% reduction in all-cause mortality. In the same RALS trial, there was a reduction in the risk of sudden cardiac death, a reduction in heart failure hospitalization. So we have two types of aldosterone receptor antagonists. We have the spironolactone and eplerenone. And eplerenone has been shown to reduce all-cause deaths as well, cardiovascular deaths, heart failure hospitalization. So, you know, if the patient has stage C heart failure and ejection fraction, 35% or less, you have to add spironolactone or eplerenone. If those patients should already be on a Saraharb and a beta blocker. You're gonna initiate at a low dose. So small dose. If you're using spironolactone, 12.5 to 25 milligram once daily, and if you're using eplerenone, then 25 milligram once daily. You're going to increase to 50. Okay. Again, you're going to make sure the patient don't develop hyperkalemia. You're going to make sure the renal function is okay. If there's slight impairment in the renal function, you can do every other day dosing. You don't have to daily dosing. Okay. Okay. So again, whatever medicine you're using, you have to know a little bit about it. I had a male patient who was taking aldosterone for his heart failure. His primary care, he went to the primary care, he had tender swelling in the breast, and the primary care sent him for a mammogram, a CT scan. I mean, just a simple history would have. So the patient spent thousands of dollars, and when he come, I just stop the medicine and give him something else. So there's an increased incidence of gynecomastia, breast swelling, or breast pain with spironolactone. It is less with eplerenone. So, all right. And then the risk, hyperkalemia, because it inhibits the potassium excretion, so you can get elevated potassium. The elevated potassium is about 2 to 5% in a large scale clinical trial, but in the population-based registry, it is much higher, about 24 to 36%. And it can also cause worsening renal failure, so be aware about that. So we already went with the start low, go high, know about the medicine. Renal impairment is a big thing, so you have to check the renal function frequently. You have to check potassium. So when you first put the patient on the medicine, within 3 days, you should a BMP, then in a couple of weeks, and then monthly. So you have to have a schedule for the patient. Um, especially if you're using other medicines that can increase potassium. So once you start a patient on aldactone in 3 days, then 1 week, and then monthly for the first 3 months. If you don't do that, the patient gonna develop, uh, you know, probably renal impairment, hyperkalemia, and the patient can get real sick. So be aware of that. So we're gonna stop here and finish up. There's no lecture